Off you go.
Great. So, hello everybody. My name's Matthew Costa. I'm a Professor of Orthopaedic Trauma at the University of Oxford. And today I'd like to talk to you about the UK fixation of distal tibia fracture trial. So this was a large multi-centre trial run in the major trauma networks of the United Kingdom. And it's funded by our National Institute for Health Research, which is the research arm of the National Health Service and funded by the Health Technology Assessment funding stream. As a disclaimer, I should point out that the content of this presentation has nothing to do with NHR. They've got plausible deniability for this, and nor the Department of Health either. But we're very grateful for their support for the study. Most of the work for this trial was conducted through the Warwick Clinical Trials Unit, and the team there worked incredibly hard to provide the quality of data they achieved. And I now currently work through the University of Oxford. The study was also supported by the Orthopaedic Trauma Society, which is our national organisation that looks after orthopaedic trauma in the UK. So why do we think that this study was important? Well, distal tibia fractures are not a particularly common fracture. However, they are an injury that causes a lot of problems for patients. And that's really because as soon as the bone breaks, the pull of the muscles around the lower part of the leg pulls the bones out of position. So the distal tibia, or the tibia in general, is quite a commonly broken bone, most common long bone in the leg, and that's because it sits right under the surface. It's directly beneath the skin. Fractures in the centre of the bone are traditionally fixed with a metal rod down the hollow part of the bone, what we call a nail, and that seems to work quite well for the majority of patients. Well, fractures of the distal tibia, that is the bottom third of the tibia, are much more difficult to control. And the reason for that is the bone expands at that point. So when you've got a narrow tibial nail down the centre of the bone, it doesn't fit particularly well in the distal third of the bone. So in order to compensate for that problem with this usual nail technique, the very clever plate manufacturers came up with a concept called locking plate fixation. This is something that's been around in carpentry actually for quite a while, but only relatively recently in orthopaedic trauma. And these plates, the unique feature of them is that the screw heads have a thread on them, so they actually screw directly into the plate itself. And that gives the construct, when you fix the plate to the bone, that is angular stable, so it can't move around as much as traditional plates and screws. And these plates were designed specifically for areas of the bone, like the distal tibia, where the fixation in the cortex of the bone was not as good as it is in other areas. So suddenly we had a new technology which could, in theory, give us better fixation for a complicated fracture, which usually needs surgery because the tibia is deformed at the point of injury. The problem, of course, as ever with new interventions in orthopaedic trauma, is that these plates were more expensive than the existing technology. So the question that we asked was whether the potential benefits of the plate fixation in the distal tibia were real, whether we really could demonstrate a clinical benefit for the patients, and secondly, whether the extra cost that we were consuming for the NHS and for society more broadly was worth it in terms of that increased benefit to the patients. Now, there are other ways of fixing fractures of the distal tibia, but by far the most common in the UK for extra-articular fractures, that is, fractures that don't go into the ankle joint, are nail fixation and these locking plates. So we excluded things like external fixation from this particular study, although external fixation is a good option for other fractures around this area. So who were the patients in the study? Well, as usual in these large NHR studies, we try and keep the inclusion criteria as broad as possible. So the idea is that anyone with this injury who would be having surgery was eligible. So the inclusion criteria were very, very straightforward. If you were an adult patient, and really we meant skeletally mature here, so the growth plates in the bone were closed, and we used 16 as a surrogate age for that. And in the opinion of the treating surgeon, you'd benefit from surgery, which is, as I've already mentioned, most patients with this injury, then you were eligible for the study. We then had a slight issue about how to define the distal tibia, and we could have actually taken a simple measurement of say 10 or 15 centimeters above the ankle joint. But of course, patients come in very different shapes and sizes. So rather than an absolute measurement, we decided to go for a ratio, which is the width of the bone compared to its length. And we use something called the Muller square, which will be familiar to orthopaedic trauma surgeons. It's the way we define the ankle part of the tibia, really. And if the fracture extended into the area 2 Muller squares from the ankle joint, then the patients were eligible. That was just a way of defining the distal tibia. Now, people could argue, and I would agree really, that that's arbitrary, but we needed a reproducible way that we could actually define the distal tibia, and this is something we thought that the surgeons would understand, and that certainly seemed to be the case within the study. Now, as ever with any of these trials, we also have some exclusions from the trial. So some patients clearly could not have both of the different types of intervention. And the most common reason for exclusion was that there was a contraindication to an intramedullary nail. Now, the nail, as I mentioned, goes down the hollow center of the bone. So, of course, if there's an obstruction in that hollow part of the bone, the medullary cavity, then, of course, you can't use a nail fixation. Therefore, a patient can't be possibly re-randomized in a trial to have a nail. And by far the most common reason for that was the patient had a knee replacement in at the top of their tibia, so they couldn't actually have the nail put in. There were also a much smaller number of patients who were excluded because they had a deformity or previous injury in the middle of the tibia, but that was actually just a handful of patients throughout the course of the study. Second exclusion criteria was the fracture was open, and we did think about this in the feasibility work leading up to this trial, and came to the conclusion that the outcome for patients with an open fracture, that is where the bone comes through the skin, is really dictated by the soft tissue injury, the wound itself, rather than the fracture. So that being the case, it seemed unreasonable to include patients with open fractures who might be having multiple operations with plastic surgery and so on included in this trial. And then finally, there was a small number of patients who couldn't adhere to the trial procedures or complete questionnaires. And the most common reason for this was patients couldn't understand written English. And because the outcome questionnaires were all in English, we couldn't unfortunately include that group of patients in this particular study. So that was it in terms of eligibility criteria, very straightforward. And we hope that we could capture all of the patients really who were having a closed fracture of the distal tibia fixed either with a nail or a plate. So in terms of the interventions, and again, this fits with the pragmatic nature of the study, we didn't tell the surgeon what type of plate and screws to use. We didn't tell them what approach to put the plate in through, so where the incisions were in the skin. We let them put the plates in the way that they would normally do in their hands, in their hospital, with their theatre team. As long as some of the screws at the bottom end of the plate were fixed angle, that is, it's a locking plate, which is inherent in the technique, then they were eligible to be taking part in the study. And similarly with the nail group, we didn't tell the surgeons what type of nail to use or what screws to put in or what configuration or whether to use blocking screws and so on. We let the surgeons decide what was the best mode for fixation with a nail in this particular fracture for this particular patient as per their normal practice. And so we hope that means that the patients who were involved in the study were being treated by the surgeons would normally treat them, rather than dictating a particular intervention only given by a few expert surgeons. And this hopefully will make the results of the trial applicable to all surgeons and all patients around the country, and we think we achieved that. So what about measuring outcome in this study? Well, the easy thing to do would have been to use a ankle score, some of which have been used in several trials previously. The problem with that is the ankle scores weren't particularly good at picking up other problems in the leg, and particularly pain at the knee, which has in the past been associated with the nail fixation. So in the end, we chose a more generic score, and we tested this in a pilot study before doing this full randomized trial. And this outcome is called the Disability Rating Index, and this is self-reported, so the patient tells us what they feel their own current level of disability is. And this goes from a scale of 0, which is no disability, to 100, which is completely disabled. And the questions asked in the questionnaire gradually get more difficult, so we didn't think there would be ceiling effects in this particular outcome measure as well. It seemed to behave well in this particular patient group. So that's what we chose as our primary outcome measure. As ever, we did have some secondary outcome measures, and we chose one of the more commonly used ankle function scores called the Olude-Molander ankle score. And we looked at health-related quality of life as an outcome using the Euroqual 5D scoring system. And of course, we also used that same outcome measure to determine the qualities, so the quality of life for the health economics analysis. As ever with these studies, the health economics data was actually the largest single part of the data collection. There's a lot of effort gone in by the whole team to collect data, not just on what it costs the hospital, but also what it costs the patient, or what it costs society for looking after the patient in the community, but also what it costs the patient themselves in terms of lost earnings and so on from being time off work. And a key part of the outcome data was also complications, because it's fine if one of the interventions works better than the other, but if that intervention comes with much higher risks, then the patient may decide not to have that intervention after all. So complication is always important when reporting this sort of surgical trial. So in terms of the study, it was a very simple one-to-one randomized trial. So half the patients had a nail fixation and half were randomized to have a locking plate fixation. The study took part in 28 UK trauma centres, which represented the bigger, really, units, what really became the major trauma network and some of the larger regional trauma units around the UK, including Scotland, but no centres in Wales and Northern Ireland for this particular study. Now, as I mentioned right at the beginning, fractures of the distal tibia, although they're very problematic for the patients, are not common injuries. So this was a really long study, a 30-month recruitment period, which is a very long time to maintain momentum with a trial like this. And we were on average recruiting about one patient every other month in each centre. So to maintain that sort of period of time really for a study is testament to the hard work of all of the surgeons and research teams at each of the centres, and we're very grateful for that. The randomisation was stratified by trial centre, and this was to account for clustering effects within the trial centres, so different pathways or rehabilitation or anaesthetics and so on by centre, and also by age. Age was interesting. We used that as a surrogate for bone density. So the idea of locking plates was really around fixation in very fragile osteoporotic bone, but we thought in the context of the distal tibia there may also be benefits from younger patients as well. And the epidemiology of osteoporosis in the tibia suggests that a cut-off around the age 50 separates patients with normal bone density, those under 50, who are having high energy trauma, from those who have got lower bone density, so osteoporosis or at least osteopenia in patients over the age of 50. So we use 50 as a cut-off really for bone density. And the stratification should allow, therefore, balanced numbers of patients in each arm of the trial, both above 50 and below 50, and also by trial centre. So what happened during the course of the study? Well, it was a long old study, but we did get there in the end. We achieved our 320 patient recruitment target eventually. In fact, we had 321 patients as two were randomised on the last day, so we actually slightly exceeded the target. Now, one of the things we worried about in the Costa study was crossover, because fixing a distal tibia is not a common or a particularly straightforward operation. It's technically quite demanding, and not all surgeons are completely comfortable with doing this procedure, or certainly don't do it regularly, shall we say. So we worried that some patients would cross over inevitably when the patient was actually in the operating theatre and the surgeon was proceeding with the intervention. And sometimes they might find an extension of the fracture or a particular problem with the approach that meant that some patients who were allocated to a plate went to a nail, and some patients allocated to nail went to a plate. The very good news is that although this did happen inevitably, there were only 23 crossovers during the course of the study, so lower than we anticipated in there. And actually, most of those went from a plate to a nail, 19 out of the 23. Why that should be the case, we're not entirely sure, but it may be actually reflecting of a preference perhaps within the surgeons towards nail fixation. And actually, one of the centres withdrew through a lack of equipoise halfway into the trial, because the surgeons just didn't want to put plates on there really. And actually, when we looked into the detail of which patients crossed over, they were coming from one or two smaller centres who may have had an inherent preference towards one type of fixation, in this case the nail. Fortunately, the overall numbers are very small, so it doesn't really affect the outcome of the study at all. Then in terms of loss to follow-up, which is also inevitable in a large long-term study like this, we were very fortunate, and a huge amount of hard work from the trials team at Warwick. We only had 10 patients withdrew, and therefore we had complete follow-up with a primary endpoint of 89% of the patients who were available, which is pretty good, and roughly what we expected in the study when we set up the sample size. Excuse me. So moving on, which patients were actually involved in the study? Well, we found that in women, it was older patients, and this was also expected and fits with the epidemiology of the fracture. And that's because obviously osteoporosis is more common in women, and so the median age there was in the 60s, whereas for men the median age was actually in the 30s, and that's because more men do silly things like ride motorbikes and play contact sports. So those distributions were reassuring in that they matched what we expected to find from the papers written on general epidemiology of this injury. So again, we can be pretty confident that the patients in the study were representative of the population more broadly with this injury, rather than being very highly selected, which was important for interpreting the outcome of the trial. So what do we find in terms of results? Well, this is the key graph, really. On the y-axis here is the disability rating index. As I mentioned, this goes from 0, so no disability, to 100, which is 100% disabled. And before the injury, most of the patients were nearly normal, only around 10% disability. So because some of the patients were older with previous injuries potentially or comorbidities, then of course they weren't 100% fit beforehand, but nearly, and both groups were well matched before the study. So what happened as we started to collect outcome data in this group of patients? Well, at 3 months, patients actually had recovered, but actually surprisingly only had recovered to around 50% total disability. So the average scores were around 50. And those of you who are eagle-eyed here will see that there's a distinct difference between the outcomes at 3 months between the two groups of patients. And I guess some of you want to guess which group had the better outcomes at that time point. So bear in mind, a lower score here indicates a better, lower level of disability, so a better outcome from the studies. Now, this is interesting in that there's a difference, but also particularly interesting in that there's still 50% total disability at 3 months. So those of you surgeons who are listening will be in the clinic at 3 months, and if the wounds have all healed and you see some callus on the x-rays taken at that time, you're thinking, well, this patient's doing pretty well. But the patients were still telling us from their point of view they were 50% disabled, which is perhaps something to bear in mind when we think about how patients recover from this particular injury. So what happened at 6 months? Now, 6 months was the primary endpoint for the trial. So we specified before we started the study that we'd collect the data at 6 months to compare the two groups at that cross-sectionally at that time point. And the good news again is that the two groups improved, although still reporting over 30% total disability at this point. And you can see here that the confidence intervals between the two groups actually now overlap. So we're not seeing statistically significant differences at 6 months that we saw at 3 months. So it's 12 months. Well, the two lines come together, and by 12 months, patients, although still reporting around 20–25% total disability, there's no difference between the two groups at 12 months. So what do we conclude from this? Well, it seems that by 6 months, plates and nails give you predictable and roughly similar outcomes at that point. Certainly no statistically significant distances at 6 months, and nothing at all really in terms of difference at 12 months. But there is an earlier difference at 3 months in favour of the nail fixation, so lower disability at 3 months. And if you take the total area under these curves, so total disability over the first year, it is statistically significantly lower in the nail group. So in summary, both groups of patients do equally well at 6 and 12 months, but there's probably a slightly faster recovery for patients in the nail group at 3 months, but you end up in roughly the same place, which I guess is good news for all the patients in the study. So what about other outcome measures? So if we can show corroborating evidence from secondary outcome measures that the finding of the primary disability rating is also true in other measures, that's very powerful corroborating evidence that the study results are real. So what did we find? Well, this is looking at the ankle injury score. This is the OMAS score on the y-axis here. And this is almost the opposite of the DRI in that 100 on this score is normal function and 0 is no function at all from your ankle, or no pain and function from the ankle. And what you can see here is, again, the statistically significant differences actually at both 3 and 6 months in this particular outcome measure for the OMAS scores in favour of the nail fixation group, but nothing at 12 months. So a very similar pattern of recovery in this secondary outcome measure. And in terms of health-related quality of life, exactly the same thing again. So here on this scale, 1 represents perfect health, and the patient's at nearly normal health before the injury. Immediately after the injury, they have a health state around 0, so equivalent to being dead. You might think, well, that makes no sense, but obviously if you've just broken your tibia, you can't move, you can't look after yourself, you're in very severe pain and you're pretty frightened about it as well. So if that were a permanent state of affairs, then you can argue that's a state worse than death. However, the good news is there is recovery in terms of health-related quality of life, and it's exactly the same pattern in terms of the disability pattern. So slightly quicker recovery, statistically significant at 3 months in the nail group, reduced at 6 months and disappearing really by 12 months. So again, the patients end up in the same place. And in keeping with the disability ratings, these patients, even at 12 months after the injury, are still reporting a 20-25% loss of health-related quality of life, which is quite a big hit from an injury that is not an uncommon one, breaking the tibia, shall we say. So these patients are still struggling a little bit, or quite a lot, even at a year after the injury. So complications. So as I mentioned before, we've now got a clear recovery trajectory from the function outcome data reported by the patients. But what about complication rates? Well, the good news is that the surgery seemed to be successful and presumably carried out to a high standard, because revision for failure of fixation was actually very uncommon. Only 2 of the nail group were revised and 5 patients in the plate group. Also, in terms of deep infection, and we used a strict criteria for assessing deep surgical site infection here, we only had 1 in the nail group and 3 in the plate group, so low levels of further surgery for deep infection. More worryingly was the rate of superficial wound infection or wound healing complications treated by antibiotics. And actually around 11% of all the patients actually did have antibiotics. Many of whom have these in the community, so prescribed by the GP, which the surgeons wouldn't necessarily even know about. And they were 9% in the nail group and 13% in the plate group, but not statistically significant, because the absolute numbers are still quite small. And again, no significant differences, but slightly more of the patients in the nail group had removal of their metalwork. So that's planned removal of symptomatic metalwork, around 6% in the nail group and 9% in the plate group. And of course, the follow-up for the study is only a year, so some more patients in the future may have their metalwork removed, and the patients are in long-term follow-up, but we aren't reporting that data here. So overall, complication rates in terms of further surgery were very low, but slightly more complications and slightly more further surgeries in the plate group, which could contribute to the cost effectiveness of the different interventions. So what about the cost effectiveness? What about the health economics? So there's a lot of detail here, which I won't go through for the purposes of this presentation, but essentially the costs were really very similar in terms of what happened in the hospital use. So the actual initial costs of the metalwork and surgery were quite similar, but there were fewer subsequent NHS costs in the patients having the nail fixation. And that was really driven by fewer therapy follow-up appointments and fewer further operations in the nail group. And we're just hypothesizing, really. We don't know this for sure, but the patients did report to us, another outcome in the study was weight-bearing status, and more of the patients, a greater proportion of patients in the nail group were able to fully weight bear earlier on, and so maybe those patients required less in the way of therapy. So there was a clear difference in costs, around nearly £1,000 worth of difference in terms of the nail group being cheaper, but most of that was not driven by the cost of the implant, it was driven by lower costs of rehabilitation. So in health economics terms, we describe this as the nail is the dominant intervention. So it gives slightly higher quality of life at slightly lower costs, or in this case, quite significantly lower costs. And that's very unusual, because normally one intervention may be a little bit more expensive, but give you slightly better health outcomes. In this case, the nail gave very small difference in health-related quality of life improvement, but was also cheaper. So in which case it dominates the plate group in health economics terms. I'm afraid there's an awful lot of nuance around the health economics there. That paper is now published in the Bone and Joint Journal. The main clinical results were published in JAMA last year, and it's just about to come out, I think, next month in the Bone and Joint Journal, the health economics. So those of you who are interested can go for the full detail in that paper. So what conclusions can we draw from this study? First of all, it was an awful lot of hard work from an awful lot of people, surgeons, research teams, and also obviously the patients who gave up a lot of their time to help us find out the answer to this question. The good news is that both nail and plate fixation give similar outcomes at 6 and 12 months, but nail fixation was associated with slightly improved or certainly statistically significantly improved functional outcomes at 3 months and lower total disability over the course of the year. Nail fixation was also associated with lower costs. So because nail fixation was cheaper and gave slightly better outcomes over the full year, then we can say that nail fixation is the preferred option for patients with an extra-articular fracture of the distal tibia. So what does that mean for clinical practice? Well, hopefully a clear indication that nail fixation is the preferred intervention on cost-effectiveness grounds, but plates in selected patients will give you similar results at 6 and 12 months. So certainly not to get rid of the plates, but perhaps in the future when we're training the next generation of surgeons in terms of how they fix a fractured distal tibia, we'll be looking at techniques for improving nail fixation as the more cost-effective intervention in this particular group of patients. And hopefully we'll be able to see that change in practice happen over the coming months and years. So thank you very much for your time, and I hope you enjoyed listening to those results. If people want the full details of the trial, they will hopefully be published in the NHS library. This is the 300-page report of the study, just in case anyone's having some trouble sleeping at night. I'd recommend reading the whole thing. But if you do want to go into any more of the detail, that will be hopefully published in the next couple of months on the NHS library websites, open access, so anyone can see all of that. Thank you very much.